Assalamualaikum and hi everyone. This is the first CME Basic by Metric My to resume our program since our break starting from Ramadan. So I'm sure we are all looking forward to learn more core medical skills. And as we are all aware, there is a surge of COVID cases and there is a pressing need to have at least a basic understanding of ICU care for COVID patients. So we are actually honored to have Dr. Mafeitzal with us today, consultant in anesthesiology, to teach us about the basics of ICU care. And without further ado, I would like to invite Dr. Mafeitzal to start. Thank you.
Okay, thank you Hafsah. Bismillah, kejap share screen dulu. Okay. Can you see the screen? Okay,
Yes, it's clear. Thank you.
Alright, okay. Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good evening to all, rasa macam cakap radio, so I say all listeners, but those who are streaming on Zoom as well as Facebook. And I guess I'm starting my slide with this that you can see here. The situation in Malaysia, the latest stats. For me, I look at number one, death numbers. All right, as you can see from this graph here, since last year COVID-19 in Malaysia, and this year, as you can see, the surge. And for the last 3-4 days, more than 100 per day. Of course, today is announced was 86, but yeah, we're in that number and of the increasing trend. And I think the main pressing issue is ICU care, ICU beds in Malaysia. At the moment, the last week graph that was being given out, looking at this number of the total admission. Here, as you can see, it's 883 confirmed ICU case and bed taken with 459 ventilated on ventilator. But as you know, when once some patient come in, you need confirmation. So these patients are still treated as SARI and awaiting confirmation. Imagine by last week, there were already 1,200 ICU bed used for this purpose, and half of that being ventilated. All right, and because of that, I think the need for definitely all hospitals in Malaysia are having issues of not having enough bed. Hence, the Ministry of Health has trying to increase the capacity. But the issue, of course, is trained staff. And hence, that's why we are having this CME today in terms of understanding. If any of you out there who are going to be mobilized from non-ICU going to ICU. So at least what I'm doing here in this half hour to 45 minutes, hopefully to help to have an understanding what ICU is and what is expected of you to work, either as a nurse or as a medical officer. I'm not here to teach you to become an intensivist. No, definitely not. But being able to function in an ICU care. All medical students, I mean, you don't know if the pressing need comes in. You need to, you will be mobilized as a medical student, perhaps final year nursing students. All these are possible. So I think let's start with the ICU Made Easy COVID-19 ICU for non-intensivists. Again, some basic introduction, and I will speak about the basic ICU management, and of course COVID-19 ICU issues, which is specific. So the whole talk today, we will try to concentrate, yes, basic issue ICU, but at the same time, what are the COVID-19 issues that is being monitored and why it becomes really bad, and why you have mortality in the setting. Of course, some summary. All right, so as you can see, the crisis is as such, where we are at this stage, crisis, yeah? And when we talk about having to create resources, is the space, staff, supply, standard care. And here we are already starting to use non-traditional area. In Kepala Batas, they have put up the military ICU. And of course, staff, we are not enough now. So it's time to train up or just put you in that situation where you have to be part of the system. And of course, your supplies and everything, there's something that what we have prepared in terms of capacity, ventilators. The numbers are there, but the one running it is the problem. In-tiered staff strategy, as you can see here from the Society of Critical Care Medicine, if you have a setup where in pandemic or in emergency situation, the experienced critical care physician or intensivist, you may not need a lot, because what we need from them is the brain. Hence, the setup where you have an ICU practitioner, and also the red color here is for the non-ICU trained, yeah? So in a setup of a 24-bed ICU, it is possible to only have 3 experienced peer people and the other supporting would be non-experienced. So this is the idea if we are to mobilize as much as possible to take care of patient in ICU. So that's the American model. So in our model, probably what this talk would try to encourage or try to make you understand is your role here as nurses, as medical officer, or as a runner at the stage of where you take care of these 4 patients. So my tier, we are talking about 4 rather than the 24 times 6. So this is 4. If it's a 4-tier thing, it's going to be 16. Don't worry, ni bukan MLM. I know it looks like a triangle. I'm not selling anything, but we're talking about ICU care and in terms of emergency staffing. All right. Maybe some issue we're talking about here will be the general consideration of working in ICU. Important thing here as well is when you are coming into ICU, you are not the main decision maker. It will be the intensivist, the specialist anesthetist, or the one in charge, the physician. They are the one, and you will get plenty of help. Of course, we try to look at what are the daily ICU routine and specific peculiarities, as well as do remember, many patients need ICU for reasons unrelated to COVID-19 as well. Okay, fundamentals of COVID-19 ICU care. Lately, as you can see, the interest has been there. Many people are looking here, as you can see, but ICU is just not about the machine. It's just not about this ventilator, all right? It's about the staffing. It's about the nurses, the doctors, the one in charge, medical assistants, all who are in ICU. So this is the core. Because despite not having high technology machines, you can still provide ICU care because ICU is intensive care. This is a normal setting that you may see in ICU, in an ICU bed, the patient there, and with all the machines around. Here is the ventilator, the circuit, and the tube. When we talk about tubing patient in intubated, there's a tube there with this ventilator. And the infusion pump that runs all the sedation, bagi patient tidur, feeding, of course DVT pump, and the area, and this is reaper mattress. Over here, you may not see, this is actually atas ni monitor ni, and that will be the monitor. But then again, in a particular ICU setting, who is the most important monitor? Yes, my most important monitor is my ICU nurse. Because in intensive care, it's 1-to-1 care, 1 nurse to 1 patient. So they will know every breath, every step. Oh, ini lagu. Alright. So they will know everything about the patient and they will monitor and they will be the one, your colleague, in managing the patient. Intensive care or rawatan rapi, as one of my mentor in anesthesia that I look up to, Mr. Dr. Alex Dilikan, he talks about it's actually care of the unconscious. All right, they are unconscious and you're taking care of them. So what actually happens in the ICU is what you do is you taking over the fundamentals of human function. For example, dia jadi teruk lung bag, so you are taking over the function of the lung. And in ICU, what we do is goal-directed therapy. In every time limit, time frame, there will always be a goal that you want to achieve. The blood pressure is low, we want to reach a certain mean arterial pressure, MAP. So that is what we do in that time. Of course, it's where close monitoring as the body recovers. So we take over the function. What happens is the body recovers. For example, we take over the function of the lung and we wait for the lung to recover. If we take the function of the kidney, we dialyze, we wait for the kidney to recover with all our treatment. And that is the role of ICU. Again, once a patient is in ICU, chances are patient okay, patient not okay will be 50-50, if not less or more. All right, that's the situation in intensive care or ICU. Okay, all right. Sorry, okay, lagging tadi tu. Okay, so now in ICU, so I've made this something simple. Of course, I'm giving here my picture so that you can see how I really look like. So in ICU, it's always the severe life-threatening disease, and that's why you admitted for better care, better monitoring. You will institute treatment, and hopefully the treatment goes to recovery. Most often, the treatment goes back there because of other issues that can continue to have life-threatening. Hence, the function that we take over, respiratory system. What do we give? We give oxygen therapy, mechanical ventilation. In terms of the heart, once patients may have issues on that, so we take over. What we do cardiovascular system would be the vasopressor to maintain your blood pressure. Hepatorenal is for your IO, your input-output chart balance. And of course, if there is impaired, you do replacement therapy, things like dialysis. And you have your biochemical balance. Again, we talk about the CNS, central nervous system. Here, what we institute is to keep you calm and relaxed. That's what people say, kalau masuk ICU dikomakan. The idea is to sedate. So relax, reduce all function of the body's air so the body that recover. Of course, the limb, we talk about having physio to make sure that it's okay. Lower limb, risk of DVT, deep vein thrombosis, pulmonary embolism. And of course, last and not least, not to forget, the GI. You have to maintain nutrition. You dah sakit, kita orang sakit pun kita suruh makan. So when we taking care of patient ICU, we have to ensure all these function as a human continue. And of course, protection of the gut. Again, on top of this is holistic care. We need to take care of the hygiene. ICU bukannya saja masuk situ tak mandi. No, the nurses work hard to make sure they're clean, mouth hygiene, etc. Of course, another thing is once patient not move, dia terletak tangan macam tu, things like pressure sore. So these are all be taken care of and the holistic picture of ICU care. In ICU, it's real-time physiological changes. The monitor that you have and everything will tell you second per second, beat per beat. You know, in normal ward, you have your cuff, and this cuff when you take according to your time. Tapi tak masuk ICU takkan nak buat ni every 3 minit nak. 24 jam berbirat-birat tangan kan. So you can't. So you have invasive line straight into the arterial, say the radial artery. It goes there and it takes your minute to minute, second to second measuring of the blood pressure. And you have a central line. Central line nowadays, CVP, some people use, some people don't use it because we have point of care ultrasound, which gives us more real time. But because of central line is the access, intravenous access, which is directly to the heart and directly to the body, ASAP. And of course, in ICU, rapid changes for patients, we provide you with the opportunity to see all steps of treatment. So this is something where you will only see in ICU. Whatever you manage is actually very fast. Your outcome you need, and you have to act fast. It doesn't work, you have to decide on the next step. But of course, in the tier system, as a medical officer, what your job is to run and to ensure that all these things are done. The nurses are the ones who actually monitor and see these patients according to their shift lah, not 24, but 24 hours for the duration. But at that moment in time for that 8-hour shift, they are the ones. And of course, intensivists or any physician who are in charge in ICU will do the overall plan. Of course, it's multidisciplinary. If you need a surgical referral, etc. So it works that way. All right, so that's the challenge. Okay, in ICU, there is this mnemonic that is all over the world globally. We use this, and we use this to check the basic routine care of any patient in ICU. Fast, hugs, BID. It came initially from fast hug, then hugs lepas tu BID lah. Over there, we call it fast hugs beat. But in Malaysia, kita famous kan BID, brought in date. So for you to remember, is fast hugs BID. Alright, fast hugs BID apa benda ni? Alright. So we start in terms of this mnemonic that you use, dia bukan kena ikut aturan ni, but for you to remember, so every time you monitor your patient, this is what you look at. Number 1, feeding. Feeding. Ni selalu kita lupa kan, sakit-sakit kita biar je patient tak makan. Tak guna juga bila patient nak baik. So you need to feed the patient, you need to give energy. Because when you are in sepsis or when you're in ICU, what happens is this catabolic state tau. Dia tengah pakai, badan tengah betul-betul nak replenish. Kalau kita tak makan 3 hari, sakit demam kan, terduduk je macam tu. So the same thing, but they are unconscious. We need to think what is good for them and what we do that. Second, anesthesia, tahan sakit, pain control. When you are intubated, the tube is in your throat. Ni tak selesa. Cuba saudara dan saudari cocok jari dalam tu. Terbeliak, terbahak. Kan? Bayangkan ada tube besar in there ventilating. So you need to sedate and control the pain. Alright, so these are the things, important thing to ensure. Because sometimes patient on the tube, dia ventilator, maknanya ventilator tu torong dia bernafas, tapi tak selesa, dia asyik terbatuk-batuk. It's because of the pain. So you try to give your medication to ensure pain control, pain is controlled. And then you have sedation. Sedation, definitely you have to sedate the patient. Nak patient bangun macam tu, memang problem. Because partly when you are hypoxic, you will be hypoxic in the brain juga. So you can become restless, you can become delirium, etc. All that can happen. So to settle that, especially because you rest, so you rest the brain as well. Okay? Thromboembolic event. So you tengok ni juga, apa yang you dah bagi. Patient bayangkan terduduk, definitely there will be that means deep vein thrombosis, maknanya dia akan stagnant, so you boleh cause blood clot. So that's why you need thromboembolic prophylaxis. Headbed elevated, ulcer prophylaxis penting because ni stress situation. So perut ni boleh koyak ni, they can because of a lot of acids in stress situation. And G, glycemic control. S, spontaneous breathing trial. These are actually steps to ensure that to wean the patient off the ventilator. All right, that's why you do this. But for that to decide, you have to check it to be done every day. The reason being simple je. Ni badan kita kan, kita dah manjakan dia. So badan ni boleh lupa ni, dia nak depend on the ventilator. So you need to practice this for the patient to know that yes, this function when lung is okay, we are going to return this back to you. Alright, bowel regimen, yeah, you need to make sure that the motility, everything pun. So these are the things that you have to ensure. Indwelling catheter and line, ni semua penting. You have to check and make sure that it's clean because it's a source of infection. Kalau lama-lama letak, badan patient lemah, patient immunosuppressed. So you need to check your catheter and lines, and frequent changes may be needed depending. And catheter here includes CBD, you punya Foley catheter, kencing, all the catheter, all this we check, mesti ada time routine change, etc. And of course, de-escalate antibiotic. As you know, ICU ialah tempat di mana we grow superbugs. Superbugs are multi-resistant bacteria. So you want to reduce that, you have to ensure that whatever antibiotic use is macam ada dia punya judicious use lah. That means you ensure that you do not bagi semua nak bagi bom atom. Lama-lama bug ni pandai. Macam saya like COVID-19 lah, dia smart. This year what has happened is not what happened last year. So the type of patient who come in and cause problems are totally different. Alright, so remember, fast hugs, BID. In ICU, this is key. The ICU chart, depending on where or which hospital you are in. Most modern hospitals, we are talking about HIS, so it is already integrated in the system punya computer of your punya hospital informatics system lah. But the whole idea kalau dalam ICU, if you are those yang bukan dalam HIS, you will see this big form. Ini core of ICU. Whatever dia buat or model into the system is actually this particular form, because this form akan this chart will tell me it's a daily chart, the real time charting, maknanya dia akan chart. So kita boleh tengok important in ICU care, we are talking about trend. Kita bukan cakap, hello doktor dia call BP high, satu reading je. That's not significant. Bukan mungkin high, patient terbatuk, patient terbangun ke, so benda naik. But we see the trend. Kalau macam within the hour tiba-tiba macam turun je, then we can predict dekat sini suddenly techie, so something must have happened here. Example, so it's that trend that we look at in ICU. Okay, and of course as I mentioned tadi, points of concern. And the good thing about this chart, when I come into the ICU, I look into this chart, it gives me all the information I need. That is all I need. They monitor for me, yes. I tak tengok banyak tengok, okay, BP dia berapa tadi, this punya ABG blood gas dia berapa tadi. All this in this one chart. Okay, and of course yang paling penting sebenarnya, especially in COVID ICU now, we are talking about effective communication. Just not to your staff member or the other staff in ICU, but as well as the family. Okay, the communication is there, and as an ICU staff, as ICU doctor, ICU nurse, you need to communicate. Nowadays dengan family lagi susah. It becomes difficult because it's online, you are on video phone, you are on phone, so you are communicating all bad news. And how do you do that? So, and with the staff pun problem juga. Kalau you pekak, kalau you tak dengar sangat, susah. It's everything there, and memang you have to talk loud. Even if that you tak boleh, then you have to your gesture. So these two things, talking loud, listening carefully, listening well, and hand gestures. So these are the form of communication you need to change and adapt in, especially in COVID ICU. Because COVID ICU is totally different. Okay, roles and expectation of non-ICU. Honestly, as a consultant or a specialist, if I have my MOs and I have nurses in ICU, these are my roles and what I expect of them. ICU MOs, dia kena chill. Tempat stress. So jangan stress, chill. Tapi chill yang berknowledge lah. You have to be on time. Of course, when you are in ICU, you'll be taught about organizing your thoughts. So you have this organized thinking. ICU MO should know the patient real-time status at every moment in time, or they should know how to know lah. Maknanya sometimes one MO jaga 3 orang. So they tahu all these patients, what will be their issues. And then MOs invasive line, they will insert, dia akan letak, and the alertness of patients per issue. But see, I don't need my MOs to be smart, but I need my nurses to be smart. And they have to be smart because they are my eyes, my ears, orang kata my heart for the patient. Again, the job memang for them, they akan up to date the orders, the traces, they have the close monitoring, which is the chart, what they look for, and they will know what are patient issues. The care of the tube, the ventilator, the invasive line. Ni banyak ni. Orang kata kalau tengok orang yang berselirat wire. You nak cerita kalau tengok. Kalau dulu, kalau non-COVID ICU, yes, family are able to actually see. But now what they see is what you see in majalah 3 je lah. For ICU, and no communication, no role. That's why ICU is important to know and able to communicate. Alright, so when we talk about COVID-19, as you know from this particular disease severity and dia punya timeline, in ICU, this is the level of patients that we get. That maknanya dah category 4, category 5 lah, which is already bad. You need respiratory help. So this is the point where you come in. Okay. Again, this is something from CHEST, the American Society of respiratory. So what they did is actually very nice chart ni, simple one pager, the basics of when you are in a COVID-19 ICU. So these are the principles and the understanding of what is expected. Benda ni ya, the first 10 days that you treat, basically benda ni yang kita concentrate, of course on top of other things. Okay, COVID-19 ICU journey. Once the patient is in ICU, average stay of COVID-19 patient ICU is 15 days. It can be from 12 days to 30 days, that length. I think in the initial part in Sungai Buloh, some stayed for about until 2 bulan, 2 months because of the complications due to COVID-19 yang mula-mula ni. So lama dalam ICU. Tapi itulah bila you can imagine and you can understand the problem now. Patient admitted to ICU dah book dah 10 hari. So tak boleh masuk. Itu yang penuh. So that's why the opening up of other lah, kita nak cater more beds. Superimpose comorbidities, things like diabetic hypertension. If you have acute renal injury, benda ni akan worsen, and especially with certain level of COVID-19 punya effect, which is for example the CRS, cytokine release syndrome, you can get systemic punya multi-organ failure. That's why it is stage 5 tu. Of course, several sessions of proning. Proning ni pun you tengok dalam TV kan, apa you tengok, tak asyik, tak terpusing. Kalau you tengok Facebook, asyik banyak ada orang cerita, terbalik kan. So this is a thing that you do and common in COVID ICU. Tracheostomy means sometimes you cut wind off the ventilator dengan tube. So what you do is you settlekan buat lubang kat sini kan, the tracheostomy. So that will help to wind off the ventilator easily of sedation. Again, cytokine storm, as I mentioned earlier, your daily ferritin, triglyceride, fibrinogen, all these things that you need to have look. Again, this important thing, family discussion is online and real time. Itu je, this online. You don't really do this family conference to see. And the role being given to usually are the medical officers or the nurses yang have to convey. You tengok kan majalah 3, bukan majalah 3 je lah. Nanti kan kata iklan majalah 3, RTM pun ada juga. And also the news and of course on Facebook, how they put up in terms of that last dying moment, having to inform and get the family to see. It's quite sad. It's sad, not just family member, but to the person, to the doctor or to the nurses who are dealing with it. It's not easy. All right. And of course, the last point here is end of life care. I think this is actually important. Tapi when you are in ICU, then we can really talk about this lah. I think there's another session that maybe we will go into depth in this, what we mean by end of life care. What's different about COVID-19 ICU? Again, number 1, there's full PPE ni. You pakai apa ni semua, you pakai you punya PAPR. This is the aerosol generating procedure. Why you need to be careful? Because benda ni sekarang dah dia kata lagi macam airborne. Kalau dulu the droplets, so you worry you can get infected because of that. Dia masuk dia viral load tinggi, dia bagi kat you. Dengan pakai PPE ni, you imagine. Orang cakap seronok lah duduk ICU ada aircon pakai PPE. Tak, dia punya peluh sama juga. You imagine duduk kat situ apa semua. Kalau tiba-tiba ada emergency CPR, berpeluh-peluh tu macam tu nak buat kan. Nak go out and everything. So these are the 2 things yang need. Orang pingsan-pingsan bukan yang frontliner je. Last line of defense. Kita ni kat sini pun ada juga pingsan-pingsan. Panas, peluh. All these things is the same. So within that PPE. And the basic PPE is to protect yourself as well to protect the other staff member. And you have minimal physical contact with the patient. This is something very true, which is different. Kita try to minimize contact. So banyak yang kita buat kalau ada bilik punya set up dari luar. Point of care ultrasound, this is memang COVID makes it, because kalau tak kita tak boleh, kita nak auscultate pun susah pakai PPE, telinga tak boleh masuk kan. So sometimes how you would like to know is with your ultrasound. Ultrasound you can do your lung ultrasound, you can do your DVT ultrasound, you can do your just looking at where. So this is and pasang lines pun use ultrasound. So all these ada roles dia. And of course HKW lah. Okay, healthcare workers are intermediary of patient and family for updates. And now because of this particular issue ataupun the overwhelming of ICU, we do off tagging. Maknanya after certain time of period, kita can let the patient out of the COVID ICU into the non-COVID ICU. So dia punya different level of protection tu lain sikit. Maknanya dia unlikely to infect anybody with COVID. So kita kena buat, because why? Kita kena release COVID ICU bed ni. Because we need that bed. So you, the intensivist and the management team will decide who can be katakan out of the main COVID into the non-COVID lah. So these are the pressing issue and why you need a lot. So the triad specific for all acute COVID-19 complications are, number satu, definitely we talk about ARDS, acute respiratory syndrome disorder. COVID-19 dia attack delang, lepas tu habis, dia boleh hancurkan delang, dia boleh koyak-koyakkan delang. These simple words for you to understand lah. I'm not saying that macam dia koyak-koyak literally, no. But of course we have the cytokine release syndrome. Cytokine release syndrome is the time when yang macam the earlier graph picture, the virus ni what it has done, body kita akan react. Any infection yang kita akan dapat, the body will react. Kita punya immune system will go up to fight. But what this virus does is it hyper gila-gila. It increases so much that it goes overboard. Dia jadi terlebih-lebih. Macam nak example lah, macam demam je terlebih-lebih. Example lah, bukan demam terlebih, it doesn't happen that way. But yeah, it makes the body fight so hard that it creates the system jadi haywire. And of course pulmonary embolism, this is the thing yang last year ataupun I think the difference of management has made this something not peculiar, but it happens. You have more segmental sikit-sikit ni semua, but these are the reasons for the desaturation of the patient. Okay, mainstay of COVID ICU therapy, oxygen optimization, as I mentioned before, in terms of mechanical ventilation, what kind of oxygen that you bagi, and then when you're on ventilator, there are certain management in atas ARDS, you want to protect the lung, you want to give oxygen but not too much oxygen. So it's about balance tau, it's not easy. Sama dengan your immunomodulatory agents like your steroids, your interleukin-6 inhibitor, just like tocilizumab. So ini pun timing, because like steroid, if you give too much too early, then you akan make the patient immunocompromised earlier. And the problem with that is patient become so weak, they are easier to get this orang panggil nosocomial infection. Maknanya simple je, ataupun fungal infection. If you read regarding the story yang dekat India, dia ada this black fungus punya syndrome. So these are the thing interesting lah. Kenapa boleh tiba-tiba ada and why in India, example. But it's fungal. Fungal dia tak tumbuh senang-senang. You know, those who are being immunosuppressed, yes, they will have that. And of course, your anticoagulants, this is what you use to dilute the blood lah, nak cairkan benda tu. So when you have that, so you would like to prevent your pulmonary embolism. This is just a picture, CT scan yang tunjukkan how the damage of the yang putih basically is simple lah. The putih-putih is your damage lung, and then most of these patients who come in, say for example, I make simple terms, 75% once they dah come out of COVID, sometimes they come out with just 25% of lung function. So imagine dah punya impact that way. Kalau tak teruk jadi kosong terus lah. Okay, alright. So in terms of the management, in terms of dia kata respiratory, tengok kat sini what can happen is initially you step up your oxygen, you step up your thingy. Bila tak boleh, patient in distress, you may want to put your mechanical ventilation. Ini yang letak tube with the ventilator. And of course, with ventilator, you have to do this prone positioning. Ini has to do with the physiology of the lungs, in sense of you want to perfuse the good side. So this is macam you kena terbalikkan patient. So sebenarnya you nak cerita pasal ICU, dia punya knowledge that you need to know to work ni sebenarnya tak habis ni. Orang buat JFICM ke apa ke 7 tahun ni baru boleh mengaku dia intensivist etc. So but then it's just an overview that you understand lah. And of course this is what we call ECMO. Kat Malaysia not really kita buat, but we do have this, but kita belum go into ECMO sangat lah. I think numbers as well as kita punya expertise. Alright, so imagine nak buat prone position, patient yang unconscious, you letak terbalik ni. The process itself is one thing, and then nak letak balik to take care. So a lot of things can go wrong. So especially if you are new to ICU, you want to take care. So it's all about protocol. As you can see, this macam ni is from Northampton, the hospital in UK. So they ada this picture, and every time dia buat, dia akan tick what is needed. Every time dia buat tick, and every time they care, they tick. When it's protocolized, it's easy to take care. So in COVID-19 ICU, protocol is important in the sense of what you do and what you monitor per day, every day. Okay, here is an example macam saya cakap lah tadi, the change of pulmonary embolism. Tiba-tiba patient okay, and in that instantaneous moment, tiba-tiba decide, you know. And then we're looking for, and at that time kita tak faham, then kita understand to literature, our friends, and we know it's actually pulmonary embolism. So dia ada it can recover sikit, or you can just habis patient there and then. Alright. So here is an example of one particular, say macam yang monitor lah. You tengok monitor ni kan, so many things that you can see. Okay, the normal thing as you can see, yang ni monitor biasa, yang kita ada biasa pun. Your ECG, this is your SpO2, oxygen saturation. So tengok ni 88, tak bagus lah kan. You want it to be more than 95. The blood pressure, okay, MAP of 62, 92, swinging outline. Over here kita ada end-tidal CO2 lah. Some ICU may use this, some may not, but sometimes we need that to do that in terms of our management to see ada mismatch tak. Okay, this is macam one example. One example, ada satu resource in ICU, especially for the newbies. Now what do I do punya step. Dia ada, now what do I do for a lot of reason kalau dalam ICU. So interesting lah. For example, I bagi contoh macam ni, what do I do? My patient is hypoxemic. So dia bagilah, you ada resource work. Okay, kalau you tak sure, alamak hypoxemic nak buat apa? So ikut macam dia cakap, check equipment, make sure it's okay. Second, examine the lung, tengok what can be the problem. Is the patient agitated? And of course, you want your ABG, arterial blood gas. Arterial blood gas is one single investigation which is real time and can tell me how the patient is straight away. So itu yang kita suka pasal ABG, and that's our mainstay. Benda lain tu yes perlu, tapi ini kita akan apa problem ABG. Apa problem ABG. Of course, adjusting the ventilator to improve oxygenation, call for help, ini penting, and all these things lah treat reversible. So ini available on the net ni. So there's actually about 14 indications patient on ventilator. Now what do I do? So it's a good resource if you can, kalau boleh search kat internet, memang benda ni semua free. Okay. This is an example of one of my patient unfortunately passed away. Okay, you tengok tengok dia punya ni severe respiratory metabolic and respiratory acidosis. Tengok basic excess -7, very acidotic ni. PO2, FiO2 1 61 je yang imagine, tapi CO2 dia dah tak boleh control dah. Tak boleh. Dia punya peak pressure, plateau peak pressure dah macam 60 nak meletup lang. So I mean this like end stage we can't really do, dah tak boleh ventilate. So IPS kalau good indication, maybe places like yang macam kalau good places dia ada ECMO lah that can help. And of course, okay, PF ratio okay, this is one thing in COVID ICU. PF ratio is the ratio of your PaO2 in your arterial blood gas over your FiO2, the oxygen that has been delivered. So kalau you ada, you nampak katakanlah your PaO2 is katakan 100. You bagi, okay, kata PaO2 100 something, your FiO2 berapa kan? Katakan about 0.5. So as you can see, your PF ratio tinggi. So this PF ratio, more than 300, normal. Less than 200 is ALI, acute lung injury, or mild ARDS. Ni makna lung ni ARDS lah. 100 200 dah moderate. Ni less bukan more, sorry. Less than 100 is severe ARDS. So PF ratio is one single thing because you have this oxygen that you want to give, pun you tak boleh bagi banyak sangat. Because you bagi banyak sangat, it can cause problem later. You have to protect the lung. So there are issues. Interesting kan? Kata, bagilah oksigen banyak, nampak 100. No. At certain moment of time in the management of ARDS, you want to protect the lung. So when you protect the lung, you have to ensure that whatever you do by mechanical ventilation, do not make the lung to be worse. You tak rosakkan the lung. So these are the few things. Okay. Again, this is the signs of it. Hypoxia and hypoxemia. The three main things in COVID-19, definitely you have this combination of your VQ mismatch, your shunts, and diffusion limitation. Problem dia bila diffusion limitation dia, you bayangkan the problem is at the exchange level. Oksigen masuk, dia nak tukar ke overline, tak boleh. Dah start. Macam PE, yang ini yang dia kacau. So because dia tak boleh, you don't have the exchange punya capability. So bagi oksigen banyak macam mana pun, dia tak boleh exchange dekat dalam, no point. Alright, and then of course your shunt, your VQ mismatch is why you need to do your prone. So yeah, these are banyak ni knowledge yang penting, but insyaAllah lah either your session or later on if you are to be placed in ICU, these are the things that you will understand. Because sometimes when what happens to patient, bila jadi kat dia macam tu, you need to think tau, dia bukan ABC buat jadi. So you have to think, oh dia macam ni, you see the CT scan, okay, these are the area, ada mismatch, you try your prone, tak boleh juga, atau so those things lah, decision making that we do in ICU. And again, bila ada situation where we think ada problem and they are stable and so on, nak transport the patient pula. Not easy. You know, patient dah ill on ventilator, everything set up, you nak bawa all the way to CT scan. Imagine the obese patient, 150 kilo, nak bawa ke bawah tu, with all those things intact, getting them stable to get your diagnosis kan, you do your HRCT. So these things also another issue lah, yang nak bawa ke bawah, etc. Alright, of course we talk about recovery from COVID-19, tapi bila dah recover, then you have issue macam bila dah lama sedation, delirium, prolonged ventilation, maknanya bila lama sangat you have to create a tracheostomy. and of course your infection like septicemic shock, collateral damage, and also your lung diseases lah. Alright, okay. So in terms of clinical, this is the point yang I would like to tell all of you regarding ICU bila you ada kat dalam. It's about severe COVID-19. Basically, I summarize. You have the severe disease, you're giving your treatment, the treatment sometimes doesn't work, you continue of your severity. In ICU, you do your fast hubs BID, have a check, and hopefully recover. And this is the system, all the system that you do in ICU. So in COVID-19, this is the first kacau indication lah. You become ARDS. So this is the therapy that you can give. When it goes to COVID-5, you get to CRS, multi-organ failure. All these are supported as well when is care needed, of course with the holistic care and limb need to be done. Okay, these are the resources online. Kalau you nak takat gambar ke or kita boleh share, or you can watch this recording later. Malaysia kita ada our own online training. This is basic about COVID-19. Toronto COVID-19 ICU training. Ni semua free online. All the resources for doctors or nurses, you can get it. Click and have a look. ICU basic cost, ini cost kalau betul yang ada is very expensive ni. Kalau duit Malaysia 700, you nak go for it and it's not easy because it's a program which is being done. But here our colleagues from Ireland, dia memang buat, they record this last year and it's free for you. And of course for the nurses as well, ICU nursing, good resource. This is an example dalam COVID-19 Society of Critical Care, all your resources that you need. Go and video dia, if you want to learn. And they specifically, they tahu dia punya level is for the non-ICU clinician to know about critical care. Here again, the page of your quick ICU training yang Toronto tu punya, and of course the COVID-19 HDU ICU nursing. So these are all available online. Hafsah, Iskandar, can you hear me?
Yes, we can. Loud and
okay.
clear.
Is Alhady in ke?
Yeah, in already, just in.
Okay, alright. So what sekarang ni apa on my screen tak ada apa, I tak share kan?
Still share.
Still share. Okay,
yeah.
sorry. Okay, alright. Okay. Stop share. Okay. Alhamdulillah, I have my colleague, my friend, who is a consultant intensivist in Qatar, Hamad Medical Corporation Center. What he has done is dia memang intensivist, so they have had their search I think about 1 or 2 months ago. So dia punya center ni 200 bed ICU 200 bed ICU single center. So imagine, besar tu, kita tak sampai dapat. And they had to increase to up to about 400 bed, and they had to train a lot of new non-ICU personals into their ICU. So I have alhamdulillah dia dapat kerja, dia boleh balik ni. So special appearance ni Dr. Alhady Alfian Yusof. So hopefully kita boleh share tentang human factor about training the non-ICU into ICU. Alright. Okay, mana Hadi? Tak nampak
Assalamualaikum. Boleh dengar ke?
Salam.
Waalaikumsalam. Okay.
Sekejap nak cari kameranya button kat mana.
Okay. Okay. Alhady ni, okay, just let me ask dia kalau boleh keluar gambar ke, hopefully keluar. Okay. Alhady background training dia sebenarnya dia punya first was he's an emergency physician initially by training then after that dia ada interest of intensive care. And that's why dia go to intensive care lah, because these two are critical care. Alright, Hadi, all yours.
Okay, Dr. Alhady, I'll spotlight your video, okay? Welcome.
Okay, Assalamualaikum dan terima kasih Mafi sebab invite saya. First, maaf lah kalau saya punya BM dengan English bercampur aduk sebab apa lama tak cakap 100% bahasa Melayu. Tapi alhamdulillah betul cakap Mafi sebab saya boleh hadir hari ini pun kerana the surge, the COVID, second wave surge kat Qatar dah settle down quite a lot. And now I think kita ada for the time being kita ada maybe less than 100 COVID patient, most dah jadi chronic dah dalam kita punya ICU. Masa kita paling teruk maybe around 7-8 weeks ago kita reach around 500 patient, and for about 2 minggu kita ada per day around 30 ke 40 ICU admission, semuanya respiratory failure, either on NIV ataupun intubated.
And this is single center kan, just to aware everybody lah yang listening. Ni single center ni, satu hospital. Kat Malaysia kita cakap about 500 dah 100 hospital in Malaysia. Tapi you are taking care in one hospital. Betul kan?
So the hospital yang kita buat lawan COVID tu sepatutnya ada 2 je ICU and the rest tu ward lah. Tapi at its worst semuanya jadi ICU. Semuanya bilik jadi ICU and emergency department kita kena pindahkan keluar. Kita buat tent. Kita pindahkan emergency department keluar and normal ward pun sebahagiannya ada juga yang kita pindahkan keluar dalam tent. Tapi cakaplah aircon semua. So dalam actual hospital mainly ICU and just to share sebab saya kat sini as a capacity sharing personal experience waktu kita betul-betul teruk tu referral daripada emergency department saya rasa dalam 20% saja every day. The majority of the referral to ICU is patient yang already dalam hospital. So kalau macam situation kat Malaysia tu, the referral will come from MAIPS ke, from all these different center lah. So yang datang daripada emergency department sebilangan kecil je. So hospital proportion makin lama makin jadi banyak ICU. Ward satu persatu tukar jadi ICU. Tapi challenges dia macam Mafi cakap, kalau ward tu ada katakan satu ward tu ada 20 katil, biasanya ward tu ada dalam berapa nurse, 10 nurse je kerja shift kan. Tapi bila dah jadi 20 katil daripada ward jadi 20 katil ICU, you need at least 40 ICU nurse sebab nak kerja 2 shift kan, satu shift. Kalau you buat 12-hour shift, so immediately you wondering siapa yang nak jaga patient-patient ni. Tapi alhamdulillah macam mana dah kerajaan Qatar buat saya pun tak pasti. Ada saja nurse. Tapi yang nyatanya semakin banyak patient, the skill mix semakin diluted. The skill mix semakin diluted, not just from nursing point of view, but from doctors point of view, from junior doctors point of view. So semakin kita masuk dalam pandemik, when saya kata semakin masuk dalam pandemik ni bukannya 2-3 minggu, 2-3 hari je. Maknanya esok tu after 2 hari saya find out saya dah tak ada junior ICU dah working dengan saya sebab junior ICU saya dah kena ambil, dah kena taruh tempat lain dah. And then nurses pun almost every other day kita tengok nurses yang baru. So from everywhere, everybody is helping. So I think that's why you all here, you trying to learn insyaAllah from Mafiz and rakan-rakan macam mana nak contribute as much as you can dalam situation yang desperate lah saya rasa. So nak buat apa? Yang dahsyatnya COVID ni, if you get a full expert macam saya kan, you can call saya expert lah pasal COVID, ICU consultant, atas lagi expert tak ada lah. And in the country ada berapa orang je, tapi kita ada junior kita and kita ada trainee kita. Tapi bila dah ramai sangat patient, even trainee, even junior kita pun kena jaga patient independently siang dan malam. So and then nurses, ICU nurse jadi precious commodity, So ICU nurse dia akan buddykan, akan pairkan dengan nurse yang ada some experience, and then semakin banyak patient semakin lack of experience lah the nurses. Ada berapa minit lagi Mafiz? 2 minit.
Okey, boleh.
So yang paling penting saya rasa is semangat nak tolong. Tapi another yang penting is that you have to know yang you have a lot of limitation, and from a doctor point of view kita kena banyak sabar sebab kadang kita suruh nurse buat tu, nurse buat ni, nurse tak tahu pun apa benda tu doktor, apa benda, sebab nurse bukannya ICU nurse. And kadang nurses kalau biasanya kalau saya dalam ICU, saya ada team saya, kalau saya terlupa something kan, and then junior doktor saya akan ingatkan saya, and then kalau junior doktor terlupa, ICU nurse saya akan ingatkan saya. Tapi dalam keadaan pandemik, semua orang will be functioning out of their comfort zone. So kebarangkalian something terlupa buat tu sangat tinggi lah. So memang sesama sendiri memang kena banyak bersabar. Itu lah yang paling paling penting saya rasa. And bagi doktor memang kena work hard lah. There's no other way. There's no other way. kena work hard sangat lah. Itu sajalah, tak nak cakap apa pun tak.
Okay, thank you very much Dr. Alhady. I think you can help us a bit. Nanti kita ada Q&A. I actually just saw ada satu question pasal ECMO ni. So I think nanti I will direct the question directly to you. Alright, Hafsah, Iskandar, all yours.
Okay.
Alright, so why don't we start with the questions, and then both of you can give your input if that's okay. Should we start from questions in Zoom or Facebook?
Okay, sure. We start from Zoom first. Okay, this question can be answered by both of you lah. Okay, so the first question is by Ainil Ibrahim. Thank you, doctor, for the informative talk. With all the equipments and lines attached, how much movement, bed mobility allowed for a patient? How to calculate adequate intake or output?
How to calculate. Okay, all right. So basically you calculate. You think about intake output is basically not just intake apa yang you bagi through feeding. Intake ni means whatever volume in the inotrope, example, drug yang dilute bagi 100 ml, etc. Semua tu you bagi. And output you have to consider the losses juga, not just your urine. Katakan patient tiba-tiba not tolerating feeding, ada NG aspirate, so all this calculated lah. And as you mentioned regarding the equipments and line, how much movement and bed mobility, as much as possible in ICU care, you have to move the patient. You tak boleh biar the patient tu tersenyap sorang-sorang. But of course the bed that you have, it depends lah. Kalau some patient I know dia ada repurposed bed in whole Malaysia, you ada issue because bed you pakai, you call it ICU bed because of monitoring, but the bed may not be proper bed ICU. So pressure sore semua can happen. But you try to mobilize and move patient as much as possible in that sedated condition. Hadi, any point? Tapi itulah Q&A, Hadi. If kalau you boleh banyak jawab pun I'm okay. Because I dah cakap setengah jam kan. So nak bagi you cakap banyak sikit lah.
Okay.
Input output memang problematik. Input output ni dalam experience saya jaga COVID unit ni, it's most accurate most likely dalam minggu pertama saja. After minggu pertama, whatever accumulative fluid yang you ada, most of the time dah jadi inaccurate. Banyak sangat patient yang bila kita tengok chart cakap macam oh ni positif 10 liter ni, tapi bila kita examine patient dah macam tulang dengan skin saja. Because banyak benda-benda yang tak record dalam input output chart. Benda-benda macam insensible losses. Kalau patient tu the first 3-4 days temperature is 40-41, they have a huge insensible losses through evaporation. And some patient ada some bleeding, or some patient ada some vomiting, macam Mafi cakap. Ni semua dalam 1 hari, 2 hari, 3 hari you boleh ignore. Tapi bila you dah cecah seminggu, 2 minggu, ia nampak macam and then if kalau kita dah busy kan, kita tak examine patient sangat, kita tengok chart je, 3 weeks down the line, some of these patient will be in ICU for a long time, you think oh ni positif 10 liter ni nak bagi furosemide, and yet padahal you tak examine the patient, you examine patient, tengok patient kering, patient dry. So you just need to be careful, because one of the most difficult thing jaga COVID patient ni is fluid balance, and the question is very appropriate. If you make them too wet, or you let them too wet, the ARDS in the early period may get worse. But if you make them too dry, you may risk their kidney function. They may deteriorate, go into acute renal failure, or they can go into hyper concentration, maybe increase their risk of a DVT. So you don't know. So in theory you have to keep them perfect. a combination of a fluid chart and a combination of sensible doctor yang know when to believe and not to believe the fluid chart.
Okay, thank you very much, Dr. Alhady. Next question will be, how do you do proning in intubated patient? How long usually? Any suggestion timing? Do you still continue rest tube feeding? And how to care for point of pressure? Thank you. From Esmolol.
Oh, okay. From Esmolol, like what? Dia pakai Esmolol, sorry. Okay. Okay, I just answer yang macam the first two question, then tadi you take yang RT feeding dengan point of pressure lah. Okay, proning in intubated patient is a one thing that in fact nak buat tu you need proper planning of what to do, how many people doing it, and of course the technique itself is prone with all the lines and everything to take care as you move, and of course the patient condition and what is your indication. If this question that you tanya, in fact dalam in the internet there's a lot of resources that you can see step by step of how they do it, even video. Ada our colleagues pun on Facebook actually tunjuk how we do it here and how they do it all over the world. So and we talk about timing. Timing depends on how you see it. Sebenarnya is as long as possible, but interesting kalau Hadi can share kata punya experience because we want to keep that, because the whole reason is to improve the oxygenation. Kita bukan sahaja prone, kita prone because we want to improve the oxygenation. We want to perfuse the aerated lung which are like fairly normal, that we want to maintain the oxygen exchange, because certain yang dah damage tak boleh. So that's why we do that. But not all patient kita kena prone. We have to look, bukannya suka hati, ini oksigen tak bagus prone, tak. You have to study the CT. Alright, because the whole idea when you prone tu semua, it doesn't mean that the terus kadang-kadang apa prone, patient boleh terus asystole. Ni problem ni. Ni yang kena jaga-jaga. Alright, Hadi?
Proning is a rescue punya maneuver. But at some point dalam evolution of proning dah jadi like a preventative maneuver. So as far as proning as a rescue maneuver, ni memang proven sebab ARDS yang tunjuk banyak research dalam area ni. Tapi proning as a matter of prevention, in other words, kita prone orang yang sedar atau orang yang awake to prevent, to make sure ia tak deteriorate, kena intubate, this still an open question, tak prove or disprove lagi, by the way, right? So when you talk to when you just consider the evidence base, in other words, proning a patient yang intubated, and you are right, it is not without risk. Macam Mafiz cakap, risk cardiac arrest, susah nak buat CPR daripada belakang, and you kena make sure the ET tube semua protected well. Tapi sebenarnya the biggest risk to me sebenarnya in my experience in the last 2 to 3 weeks is pressure area. So whoever asked this question memang appropriate sangat this question. So pressure area is the biggest risk, and the other one is undernutrition. The reason for that is that most protocol they will say when you prone a patient, you prone somewhere between 12 to 18 hours. So once you know you want to use proning as a rescue sebab dah hypoxic sangat, you dah tak ada apa lagi dah, so you just want to buy time with proning to say if oxygenation improve or CO2 clearance improve. So you prone, and most protocol in the world when you prone them, you tak feed them fully, you know. You tak bagi makan fully like 40 or 60 meals per hour, and you bagi makan only 10 meals per hour or 20 meals per hour, because many people say kalau you bagi banyak-banyak perut kembung, susah nak breathe and maybe patient vomit. So if you imagine, if you prone hari ni 16 jam and then rest 4-6 jam, lepas tu prone lagi 16 jam, hari ni rest, lama-lama after 2-3 days you will find that your patient will be in calorie deficit. It doesn't matter what you say, but you need food to recover. So that's something to bear in mind, that the more time you prone, and if you use a protocol where during prone you reduce the feeding, you are exposing to undernutrition and catabolic state. Pressure area, prone sekali 2 kali tak ada issue, tapi the really hypoxic patient they kena prone banyak kali. So banyak sangat patient yang lots of burns ulcer on the face, mainly on the face. So this one is unavoidable. So this one you just need to look after it as much as you can. And how many times you would prone somebody before you give up? You know, we've had patient that we prone 3-4 kali yang kita cakap ni tak jadi, or we have patient yang kita prone sampai 7-8 kali and then get better. So it's difficult to say how many times, but it's a rescue maneuver and it has a harmful effect. You are right, but you need to look after, and if you cannot look after the harmful effect, you balance the risk.
Okay, thank you very much for the answer. The next question will be from Ainil Ibrahim.
Apa ni? Itulah. Apa ni? Iskandar. I think I nak bring forward. I think ada satu question which I think appropriate kita masuk kat sini. Okay, in Malaysia kita memang at the moment lah, there's no option for VV ECMO lah. So kita ada ECMO expert kat sini. Maybe you boleh just introduce sikit in the sense of understanding what it does. Number satu. I think ada one question dia ada cakap indication apa ECMO, so we just bring that question up and get Alhady just to proceed because that's the decision, who you prone, who you ECMO. So interesting that part you can share because your center ada berapa ECMO machine Alhady?
Ada banyak.
Ada banyak. Okay, alright. All yours.
So the problem with ECMO is that it is so resource intensive. Not just from money and equipment point of view, but also from doctors and nurses. You know, if satu doctor can look after maybe 15 patient or 20 patient COVID intubated, kalau ECMO maybe that satu doctor can look after 5 or 6 saja. And this is in the acute period lah. So if kita decide nak buat ECMO, then the biggest decision that we have to make and also at the same time decision yang paling susah juga is this patient going to recover after we put all this investment? And this question, and is the patient going to recover, is the overlying principle of who gets ECMO or who doesn't get ECMO. Is the answer to this question absolute? You never know because you can't predict the future, tapi there are some indicator, right? So that's the first overriding principle. The other overriding principle is if you think this person is will benefit from ECMO and once everything recover, the lung will recover and kita can remove ECMO, the next difficult question to answer about ECMO is when to put the ECMO. So this is two major question that everybody is trying to answer. Siapa dapat answer these two question memang jadi world famous lah. So when to put the ECMO ni pun lagi susah sebab ada banyak patient yang you dah nampak macam teruk sangat dah, desaturation dah, CO2 high, tapi after 1 or 2 days after that lung slowly recover. We've seen this many times, and if we maintain lung protective ventilation, patient can survive with low saturation, low 80s, for days, and even pH of 7 with a CO2 of 90 or 80, as long as you keep looking after the lungs, lungs can recover insyaAllah. And some people say, yeah, we don't need ECMO, we just make sure we look after the lung. But at the same time, ada juga patient yang mati macam tu. So the COVID pandemic has thrown another dilemma into all this, because now part of our decision making is how much resource we put into ECMO. And ni susah lah. So even in the second wave, I can cakap terus terang lah, in the second wave kita got hit so hard, then we had to sit down and we had to say, we can't put too many patients on the ECMO, and we had to pull our ECMO nurse and start jaga ICU patient, because ECMO nurse also valuable. Kalau taruh satu ECMO nurse boleh jaga satu ECMO patient je, this ECMO nurse punya lah terror, mungkin boleh jaga 3 atau 4 normal ICU patient. So you have to start balancing. So on the second wave, in the second wave kita tak taruh sebanyak on the first wave on ECMO, tapi itu bukan sebab patient tu tak layak dapat ECMO, tapi sebab kita cakap kita dah reach our limit. And ini yang paling susah lah pasal ECMO, sebabnya kalau betul lah kita gunakan indication of who should go on ECMO, I think ratus juga. beratus je. So susah lah. So in general, kita simpan ECMO for precious patient. So precious patient, macam 2-3 orang kita taruh on ECMO is ibu muda yang baru lahirkan baby. This one kita cakap okay, this one kita ada added benefit on taruh, dan now faktor-faktor lain pula yang come into the picture. And of course kita taruh on ECMO on this patient relatively early sebab kita tak nak lung terlalu injured, nanti kan tak boleh, it's not reversible the injury. So it's a very difficult question to answer sebenarnya. It's highly linked to resource.
Okay, just bringing back to our audience. So ECMO ni maksudnya is extracorporeal membrane oxygenator. Okay, kita ada impression bahawa when the lung is really bad, you put in the ventilator, that is your artificial ventilation. Sebenarnya what it does is the ventilator helps to reduce work of breathing as the lung improve and you continue oxygenation. As I mentioned, one of the thing in COVID is habis you punya lung langsung tak boleh nak process the oxygen in terms of going to the body. So ECMO is a device macam bypass machine where you bypass the lung, oxygenation happens at the machine, masuk ke dalam badan. So this is the extra lah. The one more yang maybe kita tak familiar, but I think for today's forum, why not to just introduce and everybody to have a picture lah. Kita tahu apa semua yang ada. Okay, sekarang next question please.
This one is from me lah. As Dr. Alhady said, there's a lot of ECMO in Qatar. How about in Malaysia, Dr. Mafeitzal?
Okay, kita relatively currently ECMO ni initially daripada cardiothoracic lah yang ada, but I mean there are many types lah of this machine, but of course now kita sebenarnya the machine tu kita dah I think the last COVID kita ada generous donor who actually donate lah who actually derma this particular machine to our major hospitals in Malaysia. So the machine is all over Malaysia. Dah ada sekarang. All the major hospitals kita ada this machine, and we are learning as well in terms of using it. But again, the resources lah, benda ni is very expensive. Alright, to run it, just cost price, I can tell you it's about for 7 days we are talking about 80,000 ringgit Malaysia. To run it lah. Itu belum factor in benda lain. So benda ni ada issues of that as well. So are we going to, macam kata lah, we to have resources ni, 80,000 tu you nak jaga 5 patient ICU ke? Or you can spend it for, katakan satu hari you want to take care patient ICU, it cost you 5,000. So berapa patient you boleh jaga? ECMO ni satu je 80,000. So those are the questions that come in terms of benefit. But then just like Dr. Alhady said, a patient who you think would benefit, you know the lung, a young patient, lung dia, if you treat them well, get them rested, it can recover well. So these are the questions lah. Not easy. Macam saya cakap, pandemic ni brings a totally different dimension to a lot of things, to a lot of management, to a lot of whatever we do and our thinking. Even about ARDS. Now ARDS we view it differently. Dulu we said no steroids, but with COVID lah, steroids yes come in. But again, long term we do not know. We can only tunggu time lah to tell us on that.
Okay, thank you, Dr. Mafeitzal. Okay, like this, Dr. Alhady and Dr. Mafeitzal, how about we make it more interaction between the audience? We have 2 person want to ask question. How about we invite Intra first to ask the question? Intra? Can you unmute yourself, Intra?
I've just requested for Intra to unmute,
Hello, Intra?
I'm not sure if she's still there because I did request for her to unmute, but she hasn't responded yet.
Never mind, we proceed with Iman first. Can you unmute yourself, Iman? Hello, Iman?
Tak unmute tu.
Unmute yourself, Iman.
And again, I've requested, but Iman hasn't responded.
Oh, dia tak ni. Iman, press button mute. Then we can hear you. Kalau tak, kita tak dengar.
Kena tekan button yang ada mic tu.
Dekat bawah kiri.
All right, in the meantime, maybe we can proceed with other questions if you don't mind.
Okay, we proceed first for the other question. Okay, we talking about the proning position. One of the question they ask, how about the pregnant lady? Do you do proning position for pregnant lady?
It's a contraindication lah.
Complication lah
Tapi
Okay.
itulah the issue with this is even macam obese patient pun dia sometimes can be a relative contraindication. Imagine 140 kilo you wanna prone them. It's not easy technically nak buat, nak angkat. At the meantime, even for the patient, pressure sore. As Alhady mentioned juga, we've had patient yang in the end we had to do saucerization. Selalu orang saucerization dekat belakang kan, besar-besar macam kawah dengan. Ini dekat depan ni perut dia. Saucerization we had to do because of the pressure sore after all the prolonged proning that has happened. So no, we don't. Hadi tak ya?
The normal one, yellow. Hi. Yellow.
Intra, I think your mic is on now, so if you would like to ask your questions, you're more than welcome. Are you there? Intra?
Okay. Never mind. We proceed with the next question. Any role for pulmonary rehabilitation in patient with COVID-19 positive?
Okay, so this is talking about rehab, Okay.
Yeah.
Okay, in Malaysia, kebanyakan when we do this rehab, not at the initial stage, not at the acute stage, macam the rehab physician or rehab physiotherapists come in to do that. In terms of the masa dia dah recover, yes, they come in and we try to do that lah. Ada juga. How about your protocol lah, Hadi, in terms of rehab?
Yeah, so alhamdulillah, this week and last week, I've had the pleasure of decannulating some of my patients that I tracheostomized maybe 4 or 5 weeks ago. So the putting tracheostomy did help a lot on many of the patients who you predict that the ICU course will be prolonged. So and then of course because some of these patients we paralyze them for days on days, because they're so hypoxic and they're dying. So you keep on paralyzing them, not just 48 hours, 72 hours, but sampai seminggu, So it's expected that even when the lung starts to improve, which is weeks later, and the muscle also will start to improve, but even more slower, And mula-mula tangan boleh gerak sikit-sikit, lama-lama limbs, but after that lung physiotherapy have to start even when they are still in the bed. So I'm talking about very severe cases, life-threatening severe cases. But if they are young enough, if they have the will and motivation and tak go PTSD or tak go, the neurologically intact after they recover from the COVID illness, then inshallah they will recover. But the road is long, maybe a few weeks or months before we can remove the tracheostomy, maybe another few weeks or months before they can even walk even. But the chest rehab goes hand in hand with the actual physical and body rehab, because it's interrelated, the lung recovery and also neuromuscular recovery.
Okay. So next question from SW. As per inspirational trial, JAMA, what is your take on recommendation dose for anticoagulant for patient with COVID-19? Cat 5 lah, mostly intubated one.
Question for me?
Anyone?
Right.
Pasal dia tanya dia macam what on the recommended dose. Okay, currently kalau in Malaysia, okay, you're talking about the trial benda ni, I mean from last year and this year things are different, so it's difficult to say whether it is or it is not. The only thing that we can do is just buat lah, or just take the doses. Okay, ada about 1 milligram per kilogram for BD, ada, but then again when you take your obese patient, you calculate dia punya lean body weight ke atau punya expected weight ke, these are the issues of that lah. And I think that's my response to that. Okay lah, Hadi, to you lah.
Anticoagulation ni tricky sebab patient COVID patient ni somehow tak heterogeneous, tak sama. So some akan present mainly ARDS, some akan present mainly thromboembolic with a large dead space, and some will have a low D-dimer, some will have a very high D-dimer. Some of those very high D-dimer ada PE, some tak ada PE. And actually, if you, when you do CTPA, you will pick up a lot of segmental and subsegmental PE. So again, this is another question that's not just clinical, but also resources. I still remember at the end of the second week, of our insult, our wave, the radiology department dah give up dah, because the CT scan request berpuluh-puluh. Semuanya query PE, and semuanya because D-dimer is high, and semuanya hypoxic anyway. So at some point, I think when we really are burdened with a high number of cases, kita kena jadi sensible, right? So how to be sensible about this? Ini yang you are kena ada intensivist make the sensible judgment, because some patient you will put on prophylactic dose once a day. Some patient you put on the so-called intermediate dose. Some patient you put on low molecular weight heparin because kidney dia okay. Some patient you put on unfractionated heparin sebab kidney dia tak okay. Some patient you put on the therapeutic dose sebab D-dimer is naik gila-gila sampai. This is the first time in our medical practice that we started using D-dimer quantitatively, not just whether it's positive or negative. You go quantitatively. And of course, thank God these days for bedside echo, you are in a position to look at the RV, the right ventricle on bedside echo. That also will help your decision. In general, everybody gets prophylactic dose. If you sense that space is large, with a big gap between end-tidal CO2 and PA CO2, if you sense RV is a little bit distended, dilated, then you can escalate to either intermediate dose or therapeutic dose whilst waiting for CTPA. Do you need to rush for CTPA? I personally, I don't think so. But if you do have the capacity to do a lot of CTPA, you will find that many will come back positive with with segmental and subsegmental PE. And until now, I don't think people know, how to classify PE related to COVID, because many people feel that part of the reason that thromboembolism happened in COVID is because of endothelialitis of the vessels rather than the clotting of the blood. Does that make sense? So anyway, that's still up in the air. So anticoagulation, my advice is whatever Malaysia have a protocol, just follow that only, and break out of protocol if you sense this protocol is not right. If you want to go intermediate, my advice is buat je, and if you want to go therapeutic while waiting for CT, just buat je, as long as platelet is not so low, as long as clotting is not deranged.
Okay, thank you very
When
much.
you talk about regarding this anticoagulant, you see the initial stage macam last year, what happened when we got the first, second wave, we tend to macam you get this PE which is sudden, yang betul-betul yang you see really big, but you can't do anything, alamak dah terus, okay, patient part the way, then we say, macam now those mega dose, we're talking about 1 milligram per kilogram. 1 year ago you tak terfikir nak bagi that much BD for patient. But even in our protocol, in terms of in Sungai Buloh, what we did was increasing as we see the picture, because the initial part now I don't really see that, because the institution of medical treatment that we give, the steroids, the timing that we give, and also the anticoagulation at what period of time, of course you have to wean off and it goes depending juga kan, because that can also cause other issues, things like patient easy bleeding kan, kalau tiba-tiba ada ulcer, GI bleed, these are all the issues which you have to, is case by case basis. But as mentioned, protocol ada yang you do, but when you see lots of patients, you will see the pattern, and this is when you will decide what is best for your cohort. It can differ so much. So this is the, I mean, of course, it's not good lah, it's pandemic, but this is the interesting part lah of this disease. You know, you see that, for example, last year, the characteristic of patient come in, the Cat 4, Cat 5, you do not really, I mean here, macam to me lah, I think it's the same in Qatar. Now, patient come in, okay, tiba-tiba terus Cat 5, and it's that different generation. The earlier last year, we're talking about more than 70, apa semua, 60s relax 20 tahun, 20 tahun, okay, tak ada halnya kan, setakat semua biasa. But now we're seeing them, sometimes tak ada comorbid, they are fit, they are people, orang buat Iron Man, they become Cat 4. So these are the dynamics of this smart lah, a very smart virus. Very smart virus.
90% of our patient in the last 2 months are all between the age of 25 and 50. You know, masa I was looking after 20 patients, I have 2 patients je 70 and above. The rest are young and healthy. Okay. And I think kat Qatar partly explaining that is because when we roll out kita punya vaccination, we roll out to elderly population first, you know. So alhamdulillah, the elderly, by the time we got hit with the second wave, majority of the elderly population already vaccinated, alhamdulillah.
Interesting. Qatar is you dah achieve berapa population vaccination?
I'm not sure the exact latest number, tapi I think dah more than half.
More than half. But then itulah kita tengok, that's why one of the thing I explain that can explain why the young kan, the virus dah jadi smart. So I think in terms of kita, kalau kat Malaysia ni kita encourage for vaccination lah. One probably of the reason.
Okay, I think we have a lot of questions, but we're gonna let the last question. But this one I want answer from both of you. From Dr. Amma from AD Hospital Sungai Buloh. What are your thoughts of pulse doses of steroids for managing organizing pneumonia? They said they have a problem, this 50-50 between the ID team and also the ICU team. So first we let Dr. Mafeitzal first to answer this question.
Okay, patutnya ni untuk non-intensivist ni. So ni soalan-soalan intensivist ni. We talk about pulse, alright? We're talking by right, the topic hari ni is ICU for non-intensivist. As you can see, ID and intensivist, dia ada this, ada, I mean even tocilizumab, you don't have to go, tak payah cerita pasal pulse steroid lah, cerita pasal tocilizumab. There are opinions on go and against, bukan against lah, the delay and the priority. So yes, pulse tu there is a practice, tapi depends on what's your dosage pulse ni. Ada bagi mega super dose. I think Americans dia tak bagi as much. So if you ask me pun pun susah nak cakap, because it's by right all these cases memang you really need to case by case basis. Certain patient akan benefit based on their comorbidities, based on what they do, because the problem is yang steroid ni, the issue is we don't want to overgive lah. So bila overgive, dia bawa a different perspective problem pula, which lagi pening daripada COVID ni. Dah lah, COVID dah settle, then you have this other thing, especially organizing pneumonia. I think for also the benefit of the audience, macam saya cakap lah, dia ada something orang kata the new keyword lah, macam the ongoing kan. Kau tak tahu, you tak tahu, OP ni organizing pneumonia. Apa benda ni kan? It's pneumonia, organizing pneumonia, and related now lah is the in thing. So what it is actually the pneumonia is actually just means the inflammation of the lungs. Okay, when you talk is inflammation. So inflammation ni they can't put directly as a bacterial pneumonia, or what's the cause. So that's why they call it organizing pneumonia, because of the changes and inflammation because of the disease, which has made it as such. Okay, so Qatar punya cerita, pulse steroid.
Yeah, we do it.
Habis cerita, yes.
Yeah, we do it. So if you think is the right time, and you think what else can save this patient's life, just do it. Most of the time, when you make this decision for pulse steroid, you are cornered. You are cornered already, and patients dying already. So you go the biggest dose that you brave to, as brave as you are able, you want to give, and then just go for it, because in the early period, it could be this cytokine storm. In the later period, it could be severe inflammation because of organizing pneumonia. And you know, I you know, for some patient they die anyway. But I've seen quite a few miracles, you know, when I say, you know, nothing else to do, saturation 60s and 70s only, CO2 100. But because I'm persist on lung protective ventilation. You know, I don't break the rules of lung protective ventilation to chase the CO2. I definitely don't chase saturation. So if you reach a maximum of a PEEP that you feel appropriate for the patient, and FiO2 dah 100, and you know, peak pressure dah 32, 33, most likely plateau pressure dah 100, tidal volume also you dah reach, you know, maybe 300, 400. So if you think you dah reach, then don't go higher. So even though maybe at that time CO2 is 90 or 80 and pH is 7.1, 7.2, because if you want this patient to survive, you need to look after the good lungs, and you will not be able to look after the good lung if you start damaging the good lung as well by chasing numbers. So at that stage, often we use nitric oxide. We use a lot of nitric oxide.
Okay, ni kat Malaysia tak ada, kita tak buat. Okay. So that different, I mean, yeah, it's good for everybody listening to also know what the where you go and why you want to use nitric oxide. Yes, theoretically in textbook when we talk about to get that, ya, tapi kita kat Malaysia memang maybe in pediatric ada in the unit, tapi not for COVID lah. I'm talking in general, the usage. General ICU, I would memang berani cakap lah, memang tak ada orang pakai. Okay.
So if you don't have, then some of us use inhale iloprost. So inhale iloprost, you know, a 20 microgram 6 times a day. So these are all pulmonary vasodilator basically. So again, these are rescue maneuver. This functions similar to proning. And then of course, when you absolutely cornered and you're relatively confident that this is not bacterial, this is not, you know, septic shock bacteria, then you know, this is the patient own immune system or major inflammation because of organizing pneumonia, then give pulse steroid. Dan kalau nak give pulse steroid, jangan give main-main lah, give proper dose.
Proper dose means bometom lah.
Yeah, and subhanallah, and I've seen in 1 or 2 patient, you know, I thought I come back tomorrow dah tak ada, you know, I come back tomorrow, subhanallah, they survive. And you know, so of course kita tak tahu adakah that pulse steroid ke whatever kan, tapi I did not add anything else.
True lah, as you mentioned, you are right. I think this pulse thing we think of atau macam okay, let's have a go when you're totally like you don't know what else to do. And yalah, that I have to agree. That is one method that kenapa kita nak buat lah. Macam tak tahu, okay, come, jom, let's do it. Because otherwise next day maybe dah tak ada, then recover, yeah, we do get that as well. Tak dengar Iskandar tengah cakap.
Dengar tak? Okay. Sorry. Quite interesting about the inhaled iloprost, because in Malaysia I'm not sure whether we have inhaled iloprost or not. We usually give it for the scleroderma lah, for the patient, for the vasodilator, for the periphery. So quite interesting that you have this kind of medication in Qatar. Like this, we have another one question, but this one pertaining to ventilatory setting lah. From Dr. Amma also, from ED Sungai Buloh, in intubated patient who are in ED for more than 3 days, start to develop metabolic alkalosis to the extent pH 7.5. More previously, patient who have normal bicarb gradually go up from 35 to 36. Even though we are managing hypercarbia with the ventilator setting, any thoughts on this and any role for acetazolamide? This will be the last question.
Ini soalan tengah kes ni tengah ada sekarang lagi kat ED ke? Okay, just for Hadi information juga, kita because of the banyak, I mean case lah, we can't really get the beds, so patient actually stuck in ED in terms of to get them to ICU. So there's this intermediary care which our ED physicians are doing as well to ensure that this being done. So I guess one of them is Dr. Amma, And I guess this question, I put it to you lah, especially ED setting.
Yeah. So one of the biggest problem I feel is that kita chase number, okay? Kita chase PaO2, kita chase PF ratio, and kita definitely chase PaCO2. Tapi sebenarnya the body, subhanallah, the body, once you sedate the body, once you paralyze the body can hidup lama juga with saturation of 80s, saturation of 80s and CO2, very high CO2. Kalau tak percaya, some of these patients, you just check their lactate and you just check the urine output. As long as cardiac output is good, as long as their heart is good, then insyaAllah oxygen delivery is adequate. So unfortunately, kita tak boleh measure oxygen delivery. So oxygen delivery is a function of how much oxyhemoglobin and cardiac output and vasoconstriction, vasodilation, and also tissue utilization of oxygen. Anyway, the surrogate marker for that is lactate, and also an organ perfusion, the simplest one, urine output lah. Sebab you can't check the brain kan, so they're intubated and sedated. So next time you have to chase some parameter on the ventilator, just think again, because your objective is not chasing parameter on the ventilator. Your objective is to make sure that the patient's cell gets enough oxygen, right? And subhanallah, the body is amazing, because you need to read up about Haldane effect, and the more acidotic the blood is, the more acidotic to a certain limit, the more efficient the oxygen clearance, and also the more efficient oxygen uptake at the cell. That's why when you run, your body becomes a bit acidotic, your body becomes more efficient. So don't underestimate our own body coping mechanism, right? So I know it's a bit long-winded, so now I'm going back. So what do you need to chase in terms of ventilator? So the only thing that you need to chase, in my opinion, is good enough saturation. So low 90s is fine. If the patient is so hypoxic, then 80s pun okay, if you would reach FiO2 100, that's fine, 80s okay. So PEEP, how much PEEP? Some patient perlu high PEEP, some patient perlu low PEEP. Some patient perlu high PEEP in the first few days, some patient after 1 week, 2 weeks, lang dia dah fibros, dia perlukan low PEEP. Because if you keep a high PEEP, then you just transferring unnecessary pressure. So this one, you need intensivist to help lah, right? What is the appropriate CO2? The appropriate CO2 is when the pH is not lower than 7.1 or 7.2. And this appropriate CO2 will change over the first few days patient intubated. Subhanallah, Allah gives you the kidney. Kidney is quite amazing, because within a few days, the kidney will sense the CO2 in the blood is high. So the kidney will try and compensate by making or keeping a high amount of bicarb. So the high bicarb in the acute period is helping, because it makes the blood less acidotic, right? If the patient is recovering, right? If the patient is recovering, for example, 2 or 3 weeks later, because patient has survived the first 2 to 3 weeks with a pH 7.2 every day, and you maintain your lung protective ventilation, you don't break this protocol at all, then maybe after 3 weeks, when the lung starts to recover, then the patient starts blowing off more CO2, then at that stage, patient will be alkalotic. Now, in my opinion, at that stage only, you would use acetazolamide. So only in the recovering phase, when you start sensing that the lung is recovering, when you start sensing that the body don't need so much bicarb lagi. In the initial period, you need the extra bicarb, because that will allow you to run the patient at a high CO2. just like your COPD patient, right? Your COPD patient, they come to your emergency department because they have a backup of 40. And because they have a backup of 40, they can survive with a CO2 of 80 or 90. COVID patient will develop that as well in my experience, but it'll take a few days. So in the first few days to your acidotic tu, you kena persist lah. Does that make sense? So acetazolamide only in the recovering phase when you sense patient is alkalotic because of themselves and not because of your ventilation strategy. Oh, by the way, another important lung protective strategy that not many people talk about is a mechanical power. So don't underestimate a patient that you are ventilating at a rate of 30 versus that you are ventilating at the rate of 24, So if you think, if all the parameters is the same, all the PEEP and tidal volume is the same, and you think, oh, this patient, I need to ventilate at the rate of 30 because I like a normal pH, right? That extra 6 breath a minute, right? This patient is you ventilating with rate of 30, that will all translate into mechanical power. And mechanical power, if you open and close alveoli, at the end of the day, is damaging. It's just a repetitive and shearing injury. So for me, that's why I check my patients every day. So if their pH, if their pH is 7.4 in the early period, I'm actually not happy with this. That means we are over ventilating. You see, even though this is normal pH. So I would, because most of the time you see some doctors, they will hyperventilate this patient. And don't underestimate you reducing the mechanical power because this patient needs every little help. If you can save them from 4 breath a minute, times 24 jam sehari, that's dah beribu-ribu punya alveoli open and closing, So you're not chasing CO2, you just maintaining a reasonable pH, and a reasonable pH is 7.2. And you don't need to give acetazolamide for alkalosis in the early period because most likely alkalosis in the early period is your wrong ventilation strategy. But if you see the alkalosis when the patient is starting to breathe by themselves and you sense that the lung is not so bad, now at that stage, maybe you can consider acetazolamide.
Okay, thank you very much, Dr. Alhady, Dr. Mafeiz. Okay, I think that's all for the Q&A session. I will give the floor to Dr. Hafsa.
All right, thank you, Is. And I would like to thank our guests, Dr. Mafeiz and Dr. Alhady, for joining us tonight. I know you're both very busy. Dr. Mafeiz himself were busy all day, and yet we had a very energetic discussion, and we gained a lot of useful insights. I can see Dr. Mafeiz can still smile there after a long day and night. So thank you for your time. We really appreciate it. And maybe if we both have time, we can arrange for another session in one of the weekends. I think we do have more questions, but unfortunately, we do want everyone to have a good rest. Before we wrap up, I would like to promote our event for tomorrow. We have chest X-ray, another step ahead basics by Dr. K tomorrow, 6th of June at 8:30 p.m. So Malaysian time. So for those of you who are free, you can join us for teaching tomorrow. Again, thank you so much to both guests, and I hope everyone benefited from this program. And I look forward to seeing you guys again at a later stage. Thank you so much. Assalamualaikum, and have a very good evening. Before we end our session, I would like to share the poster for tomorrow. Just 1 second. Okay, can you all see the poster for tomorrow?
Can see.
All right, so I leave it there for a few seconds.
We have a CPE point for this next session for tomorrow.
Yeah, perfect. Yeah. Okay, all. I think that's it for tonight. Thank you so much. Have a good evening. Have a good rest. Assalamualaikum. Take care.
Okay, thank you.
Thank you. Hadi, thanks Hadi.
Thank you.
Thanks.